Good morning, everyone. We're really happy to see you here today. I'm Dr. Deanna Helsher at the UT School of Public Health, and I'm Director of the Michael and Susan Dell Center for Healthy Living, and I'm pleased to welcome you this morning to our third annual Nader Lecture. Dr. Phil Nader dedicated his career to the advancement of child health, and his contributions to our understanding of early life cycle systems cemented his legacy of health. This annual lectureship has two main objectives, but primarily it's set about to strengthen the nexus between health theory and practice. So first, the lectureship is designed every year to inform academics, providers, public health students, and community members about early life cycle systems. So Dr. Nader was a big believer in origins of health, starting with the pregnant woman and extending on through infancy and childhood. And so that's really what we're going to highlight here today. We're really fortunate to have two academics here, Dr. Radek Kukowski and Dr. Steve Abrams, to talk to us about what happens prenatally and then postnatally. So we think that this is going to really be an inspiring lecture. And both of them are at the Dell Medical School in Austin, where our Austin campus is located. Secondly, this event and the surrounding activities are intended to stimulate conversations. So Dr. Nader was a pediatrician, and he really believed in connecting pediatricians with academics, with health behavior specialists to kind of work together for child obesity prevention and also prevention of other chronic diseases. We are so thankful to Dr. Nader for his leadership, and we look forward to honoring his legacy at the end of this lectureship. He passed away about a year and a half ago, and we were very fortunate to have him at the first lectureship. And so it's always nice to have this time to remember him. So at this time, I'd like to make a few housekeeping, go over a few housekeeping items. So first, I'd like to recognize everyone who put the lectureship together. So if you could please stand, Dr. Srila Sharma, who heads up the Nader Lectureship. So, Julie Basham, Kate Neal, Kate, if you could stand. Veronica Rodriguez. Oh, she's standing already. Amelia Piccolo. Chelsea Heron. Melissa Dano. There she is, in the back. Tiffany Menendez, who's joined us there in Austin. And then Sandra Vandenberg. So we'd like to thank them for pulling this all together. It's really been a great event. So next, if you could make sure that your cell phones are silenced so that they don't interrupt our speakers, we would appreciate that. There will be an opportunity for audience questions at the end of both presentations, so if you don't mind holding your questions, and then we'll have a question and answer round after both presentations are over. And so one other announcement I'd like to make is, since Dr. Srila heads up this lectureship, it's good to announce the Srila Sharma Fellow. So we have elected a new Sharma Fellow for this year. So we have one who's already in place, but we have someone new for the fall, and so it's Jenny Iyer. So she will receive a scholarship, plus she is able to work with Brighter Bites and work on a very important project. So once again, we'd like to honor Dr. Sharma and her husband for setting up the Sharma Fellowship. So if you could lead me in a round of applause. And now I'd like to formally introduce Dr. Sharma. So Dr. Srila Sharma will be introducing our first speaker this morning. Dr. Sharma is the Associate Professor of Epidemiology and Human Genetics and Environmental Sciences for the UT Health School of Public Health. She is a faculty member at the Michael and Susan Dell Center for Healthy Living, and she's co-director of the Dietetic Internship program here. Her current work on healthy eating, active living, and we've got a lot of the staff here as well from that project, known as HEAL, is designed to promote healthy birth outcomes and prevent maternal and childhood obesity. Please join me in welcoming Dr. Sharma to the podium.
Thank you, Dr. Holscher. So it is my pleasure to introduce the first scientific presenter of the 3rd annual Phil Nader Legacy of Health Lectureship, Dr. Nader Bukowski. He has a very cool title. Dr. Bukowski is Associate Chair for Investigation and Discovery in the Department of Women's Health at Dell Medical School at UT Austin. And he works to improve the health of women and promote equality and care delivery for women. Dr. Bukowski is an OB/GYN by training and an internationally recognized expert in maternal fetal medicine and has received numerous awards, including the prestigious March of Dimes Award for Best Research in Prematurity. Please join me in welcoming Dr. Bukowski to the stage.
First, thank you very much for the invitation and for the very, very kind introduction. You probably don't deserve the majority of it. And I would like to start by apologizing because I think that this lecture might be a little bit slightly different what you normally, what you would expect and maybe what you also hear. But I'm very happy that I am able to share this with you. So if this is something that is not of interest to you, I'm very happy. You are very welcome to turn on your cell phones and we'll go from there. So, in essence, I would like to, I think that you are all probably very well aware that we are in a state of healthcare crisis in this country. And probably also more than in the US. But in the US, this is especially pronounced. I'm sure that you know that because I think it's almost impossible not to be on the receiving end of this, either as a patient, as a provider, even just by intuition and interaction with others. I think what is perhaps is a little bit less known what really are the causes of this, and we may not know all of them, but I would like to propose to you that there is the main problem is that our approach to the way we conduct research in general, in medicine, in healthcare, how we apply the results of those findings, into our diagnostic tools, into our therapeutic interventions. And the reason for that, I think, is that all these actions that I just mentioned, so our research, our diagnosis, our treatment, are based on averages. And this worked very well for a long period of time because we didn't have the capacity or abilities to deal with these complex problems. But I think we are now at the verge of when things can change. And I think this hopefully is going to be a little of a silver lining at the end of this perhaps very depressing lecture. This is the GDP of the United States and its essentially division into the main parts last year. As you can see, that this part here, the part which is basically in blue here, which is the healthcare, is a major part. It's almost 20%. It's a huge amount. We went something $1 trillion, and we definitely outstripped all the other, or could say maybe it's not a bad thing, to invest a lot of money into healthcare, and that maybe we have a better results. And you perhaps know this slide as well, but in essence, what it shows is that this is the health expenditures in several countries, mostly European ones, but not only, and versus life expectancy. So basically, how the life expenditure, how the expenditures for health correlate with the increase in life expectancy. And I think I like this picture because it's very clear. One could say a lot of different things and opinions and other things, but in essence, it's clear that we are spending more and more, and we are getting less and less in return, at least in life expectancy. I think what is especially concerning is that we essentially, this curve is, since the 1970s, we are basically departing from the rest of the pack from the other countries. We are spending more, and one could say that probably in the last 4, 5, 6 years, we are spending with essentially without any significant improvement in longevity. And this is also probably true for other things. So I would like to propose that this part here, this departure between how much we are spending and how much are spending people or countries that are in the middle of that pack, with basically countries with the same life expectancy of ours, is about 5 times. So if you the countries with the same life expectancy as ours, at least in 2014, we're spending approximately $2,000. We are spending almost $10,000 per person. And what is it? We could call it different things, but in essence, this is just a term I made up. But one can say it's over-utilization. So we are spending money on things that are really not resulting in improvement of outcomes, which we hope that they are going to do that. And this is a big one, 5-time increase in expenditures. It's substantial. What are the causes? This is it has been proposed that all leads essentially to, or is driven by 3 main things: the bias information, and I will propose that this is the issue with averages and individualization of care, conflict of interest, and defensive medicine. Bias information is, as I mentioned, our approach that we treat everybody the same, and essentially in our research, in our diagnosis, in our treatment, and we basically make a decision about diagnosis or treatment based on average findings. And we will dive into this a little bit more. The other 2 are the conflict of interest. We're living in a classic fee-for-service healthcare system. In essence, this is a system that incentivizes doing more, diagnosing, doing more diagnostic tests, doing more treatments. And that's just by definition. I'm not saying that this is my opinion about it. This is how it is. And the second one is obviously defensive medicine. And this is a quote that I think puts it very succinctly and probably very well, that it's a suit for over-testing, over-diagnosing. There is, this comes also from publication from a group from Michael Lang Institute in Berlin, get big answers, and so people who do a lot of work, especially in this area. I'm just going to highlight those things because I think it's good to put these things in perspective, that there are other things than just our approach to doing practicing medicine and doing research in medicine. Defensive medicine, yes, these are very worrisome things. 7.4% of doctors get sued each year, and by age 65, vast majority of them, even in the sort of low risk from point of view of legal litigation, subspecialties, most of them get sued by the end of their career. But let's concentrate here on this biased information. And I would like to propose to you and try to make this argument to this talk, that this is all related to false positive findings that this lack of individualization basically leads to the false positive findings, and they in turn lead to more tests, more interventions, and also to problems with reproducibility of our research findings. Do we really have a problem with individualization? I would say that this is another example that shows that we definitely have to individualize. Why? This is basically spending in the United States for healthcare in civilian and non-institutionalized population in 2012. And I think this is something that perhaps is the very important part here, most important. The top 5% of population, so 5% of the population is responsible for 50% of all the healthcare costs. Again, 5% is responsible for half of the thing that has been spent. So obviously there's a subpopulation that is at very high risk. This is data from Kaiser Permanente system, and basically showing in different ways the same thing, but very interestingly, again, they show that top 5% was responsible for 51% of all the health expenditures. I like this one as well, that there's, because it's not only about who is at the high risk, but it's also about that there are a lot of people who are very low risk. So again, the lower 50%, so the people who are healthy, 50% of healthy people, on them we are spending only 3% of all the health expenditures. I think this puts it very, very clearly that there are groups of patients or group of people, because some of them are healthy, that are very low risk, and some of them that are very, very high risk. And this is the basis why, an argument, a rationale, why should we individualize at least one of them. The reason I put this here because it is, at least in my mind, is staggering how big those differences are. So, in essence, despite what you think, we are all very different. And I'm going to try to argue that at the moment, how different we are. We really don't really realize, how different it is here. And by the way, how I place those images has absolutely nothing to do. It's completely random. So that's something, this is essentially data from the large study we have done in the late 90s, about 38,000 patients, pregnant women who are doing it for screening, finding basically a new test for screening for Down syndrome. But I am using it as basically just to show you something of which is my interest, and I think maybe of interest to you as well. So if among those women, if we show for the distribution, for example, of their age, the mean age was 30.1 years, and that women between 30 and 31 years constituted 2,412 out of the 37,000. So not very many were actually, proportionally about 6% were average age. Right? Here is the distribution of their heights. The average height was 164.4 centimeters. So if we just bend generously the mean somewhere between 163 and 165, so that within about an inch, it was only 183 women out of 37,000 that were actually of that mean height. This is their mean weight, 67.7 kilograms. You can see this is not the normal distribution. It's skewed. If we, let's say be a little bit generous, about 2 pounds, for a bin who is average weight, so 67 to 68 pounds. There were 771 women who were average weight in that group. And this is the birth weight of the babies. Birth weight was 344 grams. So the then for average, so between 340 and 350, there was 699 women out of 37,000. So, but I think this is the most interesting things. So I'm going to show you here it is. So women of mean age, there was 6.4% of women that were mean age. There was only 0.03% of women who were of mean age and mean height. There was only one woman out of 37,000 who was of the mean age, mean height, and mean weight. And there was actually nobody who was mean age, mean height, mean weight, and mean birth weight. However, we have majority of the analysis that have been done, and not only for the study, I don't want to say about the study, I just got the data that was easy to show. But for everything else is based on those statistics. So we are essentially modeling and looking for something that doesn't exist. And I can tell you that it has been done many, many times before. The whole work began with the United States Air Force and trying to optimize the cockpits of planes and things like this, and they realized actually there's no average pilot. Everybody was uncomfortable because and God knows what the consequences of this were. And well, you can say, okay, so all right, so we are all different. We have, somebody is a different height, but maybe it has a lower weight and other things. But what does it mean really for health, and what does it mean for medicine? And remember that this applies to all the characteristics. That includes the risk factors for diseases. It includes that determines then probability of having a disease, for example. Here's something that we have done in our study using the primary data, and we're trying to basically build a model that includes birth weight of the offspring to predict the risk of cardiovascular disease. I'm going to show quickly later on how that works. So basically we're trying to build a model which includes the outcomes of pregnancy to improve prediction of a woman is going to have a cardiovascular disease. And basically, this is the risk of cardiovascular disease based on in those 419 women. The risk of having cardiovascular disease later on in life usually was around 20 years down the road from the delivery. This did not include any of the birth weight. This is just classic priming and heart score. What you can see is that it's basically clear, right? This vast majority of people have very, very low risk. And that few people have very high risk. Why? Because the distribution of this risk factor there in this score are varied. A lot of people don't have average risk. A lot of people have very low risk. If you would put average, it's going to be somewhere in the middle. But actually, the vast majority of them have the lower one. So why is that? We can start wondering, all right, we are all different, we have different risk of disease. Most of us don't have a very high risk of those things. Maybe we have a high risk of something else. And then all points to individualization, but why does that happen? And the reason is that we are complex systems. Complex system essentially means three things. That it's made of a very large number of parts, that has a lot of connections. All those parts interact with each other, have interactions. And that those interactions, because of that they are bidirectional, create feedbacks, positive or negatives. It means the relationships are nonlinear. And I think anybody here who tried to work with this kind of system knows that this is very, very difficult problem. Very. Even for, with supercomputing, this is a very, very difficult problem. Because even if we have, some engineering problems that include complex systems, they are very difficult to solve. Because the number of these possible interactions is increasing exponentially. And then that's in things like planes, space stations, this kind of things, the modeling of climate and for example, ice caps and things like this. But just imagine human body. Human body has 10 to the 14th power of cells, 10 to 26 or 7th power of molecules. Now the interactions are 2 to that number, 2 to the 10th to the 14th power, and then they are non-linear. When you start thinking about it, then one can really realize, that it's humiliating and makes start wondering. Actually, I think brings it into very clearly to ask, why is it so difficult to do those things? So this is an example of a very, very tiny complex system. Just only to give you a little taste how this would look or visualize that essentially. So we have only about 100 of different elements that interact with each other, and they result in some outcomes. So we have 3 outcomes that are all together that are basically the 3 facets of the same outcome. Some kind of disease of your favorite one. So this part of this disease can be caused by those red lines here, by those can be through this pathway, causative pathway. This can be caused by this causative pathway. This one. This one is going to be caused by the other ones in red. And then, well, the result is basically a situation, which you can see here, that we have a complex system. Complex system basically because of all these interactions have 2 consequences. They have many others, but 2 main ones for us, for health, for medicine. One, there's no such thing as root cause. I know it's terrible. Waiting now for people to start going to tomatoes. And I know we always say, oh, what's the root cause? You look in media and open the TV, root cause of this, this cause that. Reality is there's no root cause. There are different causative pathways. In some people there is that, in somebody else is something different. They may be similar, but that's very unlikely there will be one. Why? Because there is so many possibilities that these things can happen through all these connections. And it would be very unlikely also from an evolutionary point of view that you will have one single thing. Because if it was, those individuals would not be our ancestors. They would have been eliminated by now, or a long time ago. And the second consequence is that those systems, they have developed this way because they are very robust. Very rarely something breaks as we go. Why? Because again, you have so many alternative things. If something is broken, for example, here, well, you can go the other way around. And because of that, the outcomes, the bad things, they call them failures of the complex systems, are very rare. That's great for us, but it's very difficult to study. Studying rare events is very, very difficult. Just imagine, for example, one of the things we work on is maternal mortality. Maternal mortality happens about 20 times per 100,000. It's great. And we are very thankful that it's rare. But then how difficult it is to study something like that is so rare. So these are the consequences. And I am going to try to propose to you that this is the reason why we have problems with this attitude to analyzing data, the focus on averages, as the reason why we have problems with the reproducibility of our research findings. You may have seen this study done by John Cited in 2005. He basically did something which was pretty ingenious, I think. He basically took 49 studies. I call them the golden studies of medicine. So basically studies that have been published in the best journals. 3 of them I'm not going to say where because you can read it, but I think it doesn't matter. I think it applies. But anyway, one the best of the best. And one of those journals, JAMA, actually was, I would say, impressively, they published this study themselves. So basically, he took 49 studies that have been the gold standard of medical management. Each of them was published in the top impact journals and has been cited at least 1,000 times, each of them. So what happened first was, what is very interesting is that only 8 of those studies showed that there was no effect. So over 92% of those studies were showing positive effects of something, some treatment, successful effect of diagnostic tests, high accuracy, for example, most treatments. And then what happens to them? Then you basically look at studies that have confirmed subsequent studies that of the same size or larger and comparable quality, they have confirmed the finding of those gold standard studies. And what we found out basically is that about 16% could not be reproduced by subsequent bigger, larger or similar studies. And in 16 other percent of those studies, the effect was much weaker than in the first one. So essentially, in 30%, a third of all this gold standard, the best of the best research could not be reproduced. And then he ran another study later basically showing that on theoretical grounds, this is not a surprise. It's not something that we should be surprised every time, although we all were. I'm sure everybody else, and he basically distilled it into these 6 factors which affect why studies cannot be reproduced. And I think we need to read this. I think it's very interesting. Again, I'm coming back here to this probability of cardiovascular disease in women, and basically showing that the vast majority of people have a very small risk, here somewhere between 0 and 10% only. And why I'm so showing this? Because we have a tendency, and we, including myself in this, anybody who researches health, practices medicine, has a tendency to approach it in a deterministic way. Deterministic meaning either this or that. You have it, you have a disease, you don't have a disease. You get it treated and you succeed or you don't. And or you should have this treatment versus not. The reality is it's much more complex. And I think William Osler probably said it really well. I really like this well. Medicine is a science of uncertainty and an art of probability. There's another quote, I don't remember who it is from, but I think it's also very good one, which says that that we are struggling so much with uncertainty. Nobody wants to be uncertain. Everybody wants to know which way to go, because we are the deterministic beings living in the probabilistic universe. Why is that? Why we have so much problem? Because we are not able to calculate all those things. We are basically using heuristics, and heuristics are biased. Heuristics basically means subject to psychological biases. There's a number of them. This is no time to go into the detail, but I'm just going to tell you, just highlight one thing, which I see on a daily basis, or multiple times a day, and I'm sure the students can confirm this, or would confirm it, that what we overestimate probabilities of things that happened recently to us, or things that had an emotional impact. So, for example, if you are practicing low risk population, low risk setting, you have the feeling that nothing bad ever happens. Everybody's going to be fine, and no issues. If you are practicing with a high risk patients, for example, individuals, you automatically overestimate. So, for example, I do high risk obstetrics, not molecular medicine, and I always have to kind of downgrade my first impression, and it's very difficult. That it's not everybody is going to die, not everybody is going to have a bad outcome, but actually the vast majority of patients can be completely fine. But we have a really difficult time overcoming this, and I'm sure if you give a thought to this yourself and think about things that how you estimate things that are happening to you in life, you are subject to the same thing. Because actually this was developed in the 70s, this whole concept, and confirmed by two statisticians, psychologists, Kahneman first and they got the Nobel Prize for in economics. Although there's actually no Nobel Prize. Baseline risks. The reason I'm putting this here is because we're going to move into some examples. And I think this is a very important thing to remember. Because this is all based on probabilities. Why is it based on probabilities? Because there is no perfect test or perfect intervention. There is no such thing that 100% this treatment, this pill works 100% of the time. It works, I want to say 90%, but probably doesn't work 90% of the time either. The same thing with tests. Then we don't have tests that are 100% sensitive and specific. It's probably impossible to have. We only can increase or decrease probabilities. However, we interpret those things, like they will be deterministic. And the first thing was Thomas Banks who basically did this first based in statistics. But really, I think the whole theory was developed by Laplace and should be precise. So this is going to be a few of those things, kind of the contingency tables, or confusion matrices you probably are familiar with. But and this is not to go in depth on this, only just to highlight things to give you a food for thought. So this is classic way of looking at diagnosis, right? We have people who have a positive test, and they have a disease or they don't have disease. That's all true positives, false positives, and people who have negative tests and they have either this disease or they don't have it. So and that's basically how it all looks like with true positives and true negatives, false positives, and false negatives. However, what happens if you change the baseline? So if there is very few people who have actually a disease, so the true positives and false negatives are becoming small, right? And this part, false positives and true negatives, becoming large. And what's the effect of that? Let's say that we have something that happens 0.2% of the time in a population. So we have 30 people who have a disease, and about 10,000 out of 10,000 people. Make sense? Right? 30 out of 10,000. So that means that if 9,970 people don't have a disease, that means that if you have a test that is sensitive 97%, which is probably as good as it gets in real life, then you have 29 people who have a true positive and one person who has a false negative finding. And these are the numbers for remaining, for specificity, let's say, of 99%. So out of 9,970 people without disease, only 100 people would be false positive. So that doesn't look that bad. But now let's look at what really matters. What matters is positive predictive value, right? What we want to know is if I have a positive test, what is the chance that actually I have a disease? So positive predictive value is 29 over 129, so 22%. What does it mean? That if you have a positive test, that means that you have 22% chance that you actually have a disease. And worse, it means that you have almost 80% chance that you don't have a disease. So if you have that test done, if this test, which is so good, 97% sensitive, 99% specific, if you do it in a population of patients who have a risk of 0.3%, that means that if you have a positive test, you can be fairly sure that you don't have the disease. Well, 80% chance, right? It's not so bad. So, I just wanted to tell you that this, I didn't make it up. This is actually how HIV test performs in the low-risk population in the United States. So if you are in low-risk population, and you get a HIV test, which is very, very good test, if you have a positive result, you can be almost reassured that you're probably fine. And I'm not going to go through all these things, but basically it's very easy to show why it happens. Even with very high sensitivities and specificities, if the prevalence of disease is low, you are going to have a lot of patients who are going to be at a false discovery rate. And here I just put the numbers. When you would have a risk of disease of 1%, the chance of false discovery rate would be about 86%, similar to what we have done with the HIV testing. And you could probably be wondering, is it true for treatment as well, for interventions? Well, this is basically how well the development of medications is doing. So in essence, I think that from this whole thing, the important part is here. So from the medications that are being introduced, so studies are being done on them. Only 3% from the preclinical ones, only 3% actually end up to be approved by FDA and used in clinical practice. So basically, we could say that out of 100 tests that have been done, 100 studies, 3 actually are going to only make it, so 3 are going to be actually useful. Everything else is going to be not useful at all. Although they made it into the preclinical trials. So, and this basically is also a series of studies which show that even if we would go to 10%, so we are tripling the chance that something is actually true, that medication is really effective, for example, we can find out that with standard way we deal with these things. So basically, assuming that the power of the studies are 80% and P or false positives are 5%, 36% of the studies are going to be false positives. Interesting, because remember I showed you the study from the Ionides which showed that 32% couldn't be reproduced. So there is, this is not a fluke. This is not something that just happened. I think it's actually built into the way we do this. All right, baseline risks, and I'm not going to bore you with this kind of things, but in essence, what I'm trying to show in these studies is that even if you would have this is kind of a simulation essentially, if you will have a perfect test, 99% sensitive and specific, if you apply it to low-risk population, I'm going to get to a logarithmic scale here, the vast majority of, if you have a rare outcome, for example, something that happens 1% or less, but majority of the diagnostic tests are going to be less than 50%. There can be more than 50% false positive. And there's a problem for people who are, like myself, studying rare outcomes. So for example, stillbirth would be here. Neonatal mortality, maternal mortality. Maternal mortality, even if you will find a test that is 99% sensitive and specific to predict it, the 97% of those positive tests would be false positive, just because it's so rare. And it's much worse, obviously, if you have tests that is more realistic, like with 70% sensitive and specific, then essentially almost all the tests are going to be 99% false positive. So what I'm trying to say is basically those things, that the same thing is also for treatment, that it is important for us to study and try to identify new diagnostic tests, new therapeutic interventions. But even if we find something nearly perfect, it's still, if it's applied to population that is a low risk, general population, unselected ones, we don't individualize those tests or those interventions. Vast majority are going to be not useful. Worse, so this is a test that is 99% effective, so relative risk reduction is 99%. If we assume that every intervention has a harm, that we have a harm of 1%, suddenly vast majority of people don't have the benefit, but they have harm, because most of them are low risk. Most of them are getting intervention that doesn't help them, and 1% of them is going to have a harm. And that obviously was putting here stillbirth, neonatal death, and maternal mortality, just to show you that even if we would have this wonderful treatment, if we don't individualize individualized patients, they're completely useless. They will just deliver harm without benefit. And then kind of a little, another way to look at the same issue. If we have, for example, randomized trials, and this is also another view at why we may have so much problems with our evidence, is if we have something that works, that reduces the risk of disease, a treatment that basically halves the risk of disease, so something that works, cures 50% of people, in other words. If we apply it for people who are of average risk, this is average here, by the way, but this is distribution of risk of the disease, so majority of people are going to be low risk, few people are going to be very high risk. This is the average, this is median. If you have average, if you apply averages to this analysis, and so average was 9%, we reduced it by 50%, so it's 4.5. And if you apply it to median, the median was 4%, we reduced it to 2%. The result is going to be that the mean, the comparison of means is going to be significant, and comparison of medians is not. Same reduction, same population, it just depends who we are going to use. And this is something I'm not sure you're going to like it, but it's another facet, another view why individualization is important. There's very few studies that have been done when doctors went on strikes. It's actually 7, from this study. All of them have shown that either the mortality during that time decreased or was unchanged. I'm practicing physician. So we can wonder what happens, So the first reaction is, oh, wow, they're killing people. But remember that if you have doctors go on strike, even regardless what country it is, it was Spain, Croatia, Israel, some from the 70s and Los Angeles. That does not mean that nobody gets treated, right? People don't die on the streets. What happens is that you are running a very, very basic service, so only emergencies get treated. You don't do elective things. What does it mean? You're only treating the high-risk people. And you don't treat these people who are maybe lower risk or maybe medium. And then just to finalize, this is a few things that we worked on over the years on individualization. Although at that time, actually, to be honest with you, I didn't even have that concept well formulated in my mind. This is a study when we looked at screening for Down syndrome. And basically found out that based on patients' age and their hormone levels, we can determine how high risk they are. And again, vast majority are low risk. Very, very few people are high risk. This was about the risk factors for stillbirth. And again, the same thing came out of this thing was that yes, there are something that are strongly associated with stillbirth. For example, diabetes, hypertension, lupus, and other things, but they're very rare. So, and then there are things that are very, they are associated with stillbirth. They are like nulliparity, so basically somebody that didn't deliver a baby before it was the first baby. But that's half of all women. So that really doesn't help either. So it's very important to individualize, but it's not simple, and it requires this very complex approach. This was we individualized estimates of birth weights, and this is how we looked at prediction of ischemic heart disease based on if the baby was small for gestation. And basically what we found out was that if mom gave birth to the baby that was small, she had increased risk of having ischemic heart disease for approximately 30 years down the road on average from the delivery. And that was independent of the classical risk factors for ischemic heart disease, smoking, diabetes, and other things. The advantage of this was that you have this information 30 years before you actually have a heart attack, not when you already have one, or quickly before that, 5 to And this was the same was actually was true for looking at women. This is from Framingham. They had increased risk of cardiovascular disease, so basically stroke, heart attack, and AIDS. And then on the other end of the spectrum was we found out that women who have delivered babies who are large have increased risk of breast cancer about 2.7 times. As you can see, also many years later, this age. And again, it was independent of the classical risk factors. We actually found out that when we look at the profile of the hormones in women who had a large baby, that during pregnancy they were exposed to high levels of estrogens and high levels of anabolic estrogens and high levels of IGFs, which are growth factors and non-risk factors for breast cancer. And then just a couple of things that we're doing at the moment along this line. This is a study that we had done. We are starting with some NSF funding, basically trying to identify different things that will help us to individualize care in pregnancy, which is essentially collecting information from all these wonderful devices that all of you have here. And you might be surprised, or probably you are not, that these devices are collecting a lot of information on you all the time without you actually doing anything about it. So one of the advantages is the passive monitoring location of people who participate don't have to do anything about it. It's more objective because of that. It's basically creating an app, in essence, that collects the information from other apps. So, for example, how many steps you have done, what was your GPS location during the time when you were pregnant, and how did it change? Did you talk a lot on the phone? If you made mistakes, you would texting. All these things have actually shown to be harbingers of something deteriorating in the psychology field. I think psychiatry did a lot of work in this area. And what we are hoping to do is to basically find out the things that perhaps will say, okay, something is not right. Your routine, your normal behavior changed. Perhaps it would be worthwhile to have a look, what's going on before you even realize yourself. So that's one of the things, and we are using, this is all in collaboration with our group. This is made of people who joined the function of this Texas Advanced Computing Center. Now, since they received, I think, the largest NSF grant for supercomputing, I think it's going to be the largest supercomputer in the so-called open, meaning that people who like us can actually access it in the world. I'm sure the Department of Defense was better ones. But that's essentially where the analysis is going to be done. We are doing, this is something that was submitted, and we didn't receive that information if this is going to go or not, but this is essentially kind of doing an individualized monitoring of women during labor, doing two things. One, having a prior information, a person like this is how likely she is to have a problem during labor. And if she has, then we'll interpret the monitoring based on that prior probability. So basically it's Bayesian approach, prior, individualized prior, and then likelihood from the measurements. And measurements, this is the second coolest part. This so-called e-tattoos. They are this ultra thin, like this disposable tattoos. They're made just of gold, and they can measure things like blood pressure, pulse, and hydration, and EMG. And but we are just basically using this as a proof of concept that this can be used, and if it can be used, then perhaps in another study. But the main part of it is to see if we can individualize the approach to those patients. And obviously, we started doing it in Austin. That's e-tattoos in Austin. You can't go wrong with that. Then we have an individualization of optimal time of delivery. What we found out that actually even low-risk patients, we found out that the optimal time of delivery, meaning time when they are risk of stillbirth, individual risk of stillbirth, and individual risk of neonatal death. So death of the baby before birth or after birth is minimized, This time when it's minimized varies by almost 5 weeks, 4.5 in low-risk patients, depending on the number of variables. And then I would like to leave you with this thing, which basically means that this quote, it is exceedingly difficult to make predictions because it's all about prediction. Who is low risk, high risk. And it's very difficult to do it. So Niels Bohr, I think the first person who said was actually Disraeli, Prime Minister. Very good. Thank you very much, and happy to answer the questions afterwards.
Thank you for that incredibly thought-provoking lecture. Now it's my privilege to introduce our second scientific presenter for our Nader Lectureship, Dr. Stephen Abrams. Dr. Abrams is a pediatrician and director of the Dell Pediatric Research Institute at Dell Medical School at UT Austin, which partners with faculty and healthcare providers to conduct research that creates new products, programs, and treatments to improve children's health and pediatric care. In 2016, Dr. Abrams received the highest award in the pediatric nutritional research community, the Samuel J. Foman Nutrition Award, for his contributions to helping improve the health of children through application of mineral-stable isotope research. Please join me in welcoming Dr. Abrams to the stage.
Well, good afternoon, and thanks for coming. I hope you'll find this enjoyable as we take a roll in the tour. I see some friendly faces out there in the audience, and I hope there's some in Oscar as well. What I'm going to try to do in the next 30 plus minutes is take you on a whirlwind tour of early childhood nutrition and the public policy controversies that are there, and try to give you just a taste and a touch of the battlegrounds. We're going to focus on three not entirely connected topics. The issue of infant nutrition and breast versus bottle and what's really going on in public policy in that. Talk a little bit about toddlers and sugar, formula, and juice. And then finish with a little bit about the dietary guidelines as they relate to children, sustainability, and the like. I want you to keep in mind the players in this public policy debate. The government, which is a lot of different agencies, industry, which is a key player in this. I always remind people that food in America and almost everywhere in the world is made by companies, not by governments. Okay, so when I look at food policy, you have to work with companies because they make food. The medical and scientific organizations, such as the AP, which I generally tend to represent, and the media, which has noticed and participated perhaps in the increasing politicization of nutrition. So let's begin with the opening salvo in the current breast versus bottle wars. And again, I would spend all day on this one, but I'm going to take you through a controversy that hit big time this summer. When the New York Times reported that the current government opposed pro-breastfeeding resolutions at a WHO conference and, quote, stunned people. I will walk you through what the issues were here a little bit and what all happened, at least a little bit. But I want to start the debate. I realize, trying to remember how debates are now handled in America. Everything in America is debated on Twitter. Okay? And the three sides, or more than three sides, the three sides of this debate, which I'm going to walk through, took to the Twitter wars to do it, and I just thought they were entertaining. So we start with our president, who on July 9th said, failing New York Times fake news story today about, which is that story, about breastfeeding must be called out. The U.S. strongly supports breastfeeding, but we don't believe women should be denied access to formula. Many women need this option because of malnutrition and poverty. Okay, well, all right. I don't think you read that tweet. Lucy Sullivan is a friend of mine who represents a group called the 1,000 Days Foundation, an extremely pro-breastfeeding organization. Don't let Trump gaslight you on this issue. Don't let the media frame this as a battle between breastfeeding and formula. It's not. She's right about that. We'll come back to that. That doesn't agree with everything she said. She's right about that. It's about in public health and billions of dollars a year in private profit. Not quite sure about that. And then let's throw the third side, a group called Fed is Best. Fed is Best is an organization founded by a woman and a friend of hers. And this woman had her baby become severely brain damaged because she was exclusively breastfed. Mom didn't make enough milk. The baby became dehydrated, had a stroke, and had a very bad outcome. After that, she formed an organization called Fed is Best, which fundamentally advocates the idea that most babies don't live only on breast milk and eat some formula. Okay, and you can disagree with that, but it's a very big organization. There's a lot of support out there, and that's her perspective. In other words, the default should be to give babies formula to supplement breastfeeding. Obviously, something that goes against all WHO guidance, but again, they're out there. And so she says a growing number of doctors and nurses began to question the current strategy, worried over their single-minded focus on breastfeeding, et cetera, et cetera. So this really what this is, it got a public debate going. So let me walk you through what this was all about a little bit. First, let's talk about the underlying issue of breastfeeding rates in the United States. In the United States, we mostly reach our goal of about 80% of babies breastfeeding at the time they go home from the hospital. And so these are met the goal, including Texas. Most states are close to it. In fact, the problem right now in breastfeeding or advocating for or getting babies breastfed in the United States has little to do with mothers deciding to breastfeed and everything to do with maintaining breastfeeding and the post-discharge time period. It's not quite that, but it's close. But then when you get to the goal of maintaining a 50-60% breastfeeding rates at 6 months, you see that that's essentially not in most states. So the problem is, and the debate about breast versus bottle is hardly at all about whether or not babies should or are breastfeeding in the United States. It's about the fact that women who've chosen to breastfeed are not continuing and what's going on in that. And that was what underlies the WHO debate, as I'll walk through it. Okay, so the Surgeon General report on breastfeeding, I put this to the side of this, because each one of these is a chapter you can read. All of these are the reasons, the barriers to breastfeeding, lack of knowledge, all sorts of problems related to that, social norms, I'm not going to go through that, poor family social support, embarrassment, lactation problems, employment and child care, which is a key issue, and health services issues. So that was what's flagged as the real barriers, not the breastfeeding in the United States. Now, we often think that barriers to breastfeeding are barriers for poor people. Okay, the mother that works at Walmart or whatever and can't find a place to go and pump or that sort of thing. And those are entirely real, right? Entirely real. But I point out, I love to show this slide, that points out that among the group of people you would think would be most likely to be able to breastfeed your baby, pediatric doctors in training, are totally unsuccessful at doing it because the healthcare system will not let them take care of babies who are breastfeeding while they themselves are breastfeeding. Okay? Okay, frustrated, depressed, and devastated pediatric trainees at a U.S. academic medical center fail to provide adequate workplace breastfeeding support. Okay, that's the reality. If that group of people can't breastfeed their baby because the system won't let it do it, imagine then it would carry that down socially for those moms who are working jobs that were taking half an hour off to go and pump and store your milk in a safe refrigerator. It's just not very practical. All right, so that's the real barrier to breastfeeding. All right, hang on. So, let's now talk about the controversy of what the WHO thinks about the whole background of the breastfeeding. In 1981, the World Health Organization adopted the Code of Marketing of Breast Milk Substitutes. No advertising to the public, no free samples or gifts to mothers, no promotion of products. You can read through the rest of them. No gifts or samples to healthcare workers is a key one. The vote, for those who weren't around in 1981 doing this, every single country in the world voted in favor of it or abstained. Only one country in the world voted no. And I bet you can all guess what the only country in the world which voted no is. You're in it right now. Okay? And the United States not only voted no, but philosophically said that they didn't agree with it. Okay? Now, in the United States, infant formula was not marketed to the public until the early 90s, when barriers to marketing, which were not set by law, because the United States did not sign on to this, gradually disappeared for a variety of reasons, and now every infant formula marketing in the United States markets almost exclusively directly to parents. We'll talk about that. Okay. And then, okay. The marketing of breast milk substitutes has been shown over and over again. Marketing breast milk substitutes, the bag you go home from the hospital with, which says X formula company name, etc., do affect moms. Sending mom home who's breastfeeding with a big can of formula affects her long-term breastfeeding. This has been shown over and over again. It's not controversial. Let's talk a little bit about marketing infant formula. Again, we're going to come and summarize what the WHO debate and what that was about and finish there. Marketing of infant formulas is universally done by saying that their formula, each company's formula, is closest to mother's milk. Okay? And that's where the WHO has stepped in and said, based on the code, you can't do that. You can't claim that your formula is breast milk. Okay? It's not the same thing. Well, marketing formula is closest to mother's milk. Okay, marketing a formula closest, nearest in the whole world to mother's milk. That's 1911. So people have been marketing as closest to mother's milk for a long time. What's wrong with that? Well, first of all, it's utter nonsense. Okay, what does closest to mother's milk mean? It means that doesn't take into account bioavailability. You can have the nutrient content. It says, let's say the amount of protein is closest to the amount of protein in mother's milk. Nonsense. No formulas like that. And it can't be for a variety of reasons. Chemical composition, it's not an outcome really that matters. Biological response, well, that's a great outcome, but it's really hard to determine. Long-term development, that's what we all care about. What a mother cares about or a parent cares about is that their child who receives an infant formula will be able to go to, let's say, the UT School of Public Health, just like a baby that was breastfed. Okay, so that's what they care about. But that's almost impossible to study. Just those of you who are trying to think about study design. Try doing a study design where you randomize babies to get formula A versus formula B and determine whether or not that child's first report card is going to be different. It's virtually impossible to do that study. That is impossible, actually. And safety, and we won't go through that. But again, short-term safety doesn't really mean very much. So the term closest to mother's milk is another way to take this concept. Now, you would think that the FDA, recognizing this, would not allow infant formula manufacturers to use this phrase in their advertising. Nope. In fact, the FDA has proposed a whole series of rules about infant formula marketing. The one thing that they've allowed them to continue to say is closest to mother's milk. Okay, because the FDA was literally afraid. Remember I told you, who are the players in this? Remember I told you who the players were? Okay, finding the loopholes. Well, the latest loophole triggered the whole WHO thing, and I'm going to come around and circle back to that. I give you the background of this story. The loophole right now, on a global basis, are called toddler formulas. So the FDA, by law, there's something called the Infant Formula Act, regulates the content of all infant formulas sold to babies between 0 and 12 months of age. Those are called infant formulas in the United States. There's a group of formulas, are what they're called, not really formula, of feedings for babies sold throughout the world. They're called toddler formulas and designed primarily for ages 12 to 36 months of age. Okay. They've become about 1/3 of the market for formula sales worldwide. They've become the standard by which countries around the world are getting out of and getting around the WHO rules I showed you about. Okay? So the WHO has taken this on. Again, toddler milks are no definition. Okay, they're used by the market for children 12 to 36 months. It's more complicated than that, but it's more or less the case. Their use is not supported by the World Health Organization, the American Academy of Pediatrics, etc., etc. They have no advantage over whole milk. Okay, basic stuff you just buy the carton. However, they're not regulated by the FDA. They can't be because they're not infant formula, and the law only allows the FDA to regulate infant formulas. So it's this massive loophole that the companies are using. The biggest concern about them is not that they're going to kill anybody, is that in fact what they're doing is confusing families, and therefore on a global basis. Okay, that's what the WHO battle is all about. I showed you in the first slide in the New York Times article. So in 2016, the WHO took this on and basically said that these formulas are junk, we don't want you to use them, and they also said something that was kind of interesting, which I maybe talk about question time, which said that babies should be breastfed until 2 years of age. Now that's, in the United States, virtually no one is breastfed during the second year of life, just so you know that. Breastfeeding rates during the second year of life are less than 5%. The AAP policy is a baby should be breastfed throughout the first year of life and for as long thereafter as mutually desired by the mother and the baby. That's been AAP policy for about 20 years. It's very well written by that policy, in my perspective. So this is a little different. But basically they said that toddler formulas needed to be considered like infant formulas and should not be legally allowed to be marketed. That's what the current administration rejected did. And that's what the battle was all about. So, summary of the formula marketing issue. 2018 wars. It's only partially an issue of whether breastfeeding is optimal or has substantial health benefits. But it has opened up a broad public discussion about that topic and about what it really means to breastfeed and whether or not we're pushing too little for breastfeeding or some would say too much for breastfeeding. And how the United States looks different than the rest of the world. It was largely a market about marketing rules and approaches, including toddler nutrition. Now, what would I like to see? What I'd like to see is we all forget this issue as much as possible and focus on the barriers to breastfeeding. That's the issue. The issue that's going to make a difference in the health care of children, what this conference is about, is if we make it better for mothers to breastfeed after hospital discharge, if we extend paternal leave and paternal leave, if we have a public policy campaign that actually makes breastfeeding something that we could do in America. That's what will make a difference in the health care of children. Not fighting about whether or not a label on a toddler formula can looks too much like the label on an infant formula can. But for the reason the Trump administration did what they did is they were protecting the interests of those manufacturers of toddler formulas, and they didn't want to see that used that way. So you can decide if you agree with them or not agree with them. But that's a whole complicated issue. It turned into a public discussion of is breastfeeding better than formula feeding, which is not a useful public discussion for the most part. Not that it shouldn't be a scientific discussion. It most definitely should be. But it wasn't the public policy decision. It's not the issue that controls the health care of infants in the United States. It's the ability to breastfeed. Now, there is a separate issue, which I won't go through, about the first couple of days of life, and whether or not there are more infants than we think that need some supplementation in the first couple of days of life, and whether or not that supplementation affects long-term breastfeeding rates. That's a separate discussion. And although the Federalist Best Foundation tried to turn this discussion into that discussion, they're not the same discussions. All right, that was simple. All right, now let's turn to toddlers, beyond the toddler formula, and talk about one of my favorite topics, fruit juice. Okay, about 5 years ago, all American Academy of Pediatric policy statements come up for review. And we had one on fruit juice, and we'll talk about it in a minute. I made the mistake of saying, let's just relook at the fruit juice issue and figure out whether or not fruit juice is good or bad for kids with fruit juice. And that statement, it's a very good statement, but I thought we ought to look at it. When our revised statement came out last year, I got more interviews, more media quotes, and the article on it got more of whether these things where they quote these tracker things, than anything I've done in my entire career. By far, not even close. So the fruit juice issue, unbeknownst to me, became a really big topic. All right, let's walk through it. So fruit juice and obesity. So first of all, whenever we advocate obesity, we need to know the truth. Okay, we need to know what the scientific data says. We can have our own biases. If a kid drinks too much fruit juice, he's going to be fat. We can have our own biases. Fruit juice is fine, it's healthy, it's great. But we ought to at least take a look at the literature and see what the science says first. So let's look at the science about fruit juice first. And there is a reasonable amount. And the review of a large number of studies. For the most part, it's really hard to find an association between fruit juice and BMI. Now, fruit juice has a lot of sugar in it. We all know that. Fruit juice is not good for kids. We'll talk about that. But you have to at least recognize that if we say something like no child should ever have a glass of fruit juice in his entire life, we're saying something for which there's not the slightest scientific evidence of. Okay, so you have to understand that. However, very few of these studies really do proper analysis and really sort out energy intake from fruit juice intake. And that's what be aware of that limitation in the literature. 90% of children consume fruit juice by a year of age, but that's again, and this is a perfect thing for Dr. Kowski's slide, because this points out that this outlier is actually what really matters. What we really care about is the 2% of infants consume greater than 16 ounces a day. Those are the ones that matter, and 8% of children over 45 years of age drink a large amount. So it's not means don't really tell you anything. Okay. Again, multiple analyses of these studies, consumption of 100% fruit juice has no independent effect on weight status apart from energy intake. Okay? That's the facts. But remember that key phrase here is apart from energy intake. That fruit juices are nothing more than a bunch of sugar. Okay, so they are contributing to the weight, they simply are not independent of that. So the conclusion of the evidence review, and this is from the AMD, Evidence Analysis Library, the evidence review does not support an association between 100% fruit juice and weight status radiposity in children aged 2 to 18 years of age with a fair grade 2 grade 1. Okay, so that's the science behind it. Make sure we're clear on that. So what about the AAP statement? So this first published in 2001, reaffirmed again, and then for reasons unknown, we had decided we'd revise the whole thing. What we did is we said there's no reason for children under age 12 months to get fruit juice. And here's the summary of the whole recommendations. Longer than 12 months, not get fruit juice, 1 to 3 years, limit to 4 ounces a day, 4 to 6 ounces, and 7 to 18, 1 to 8 ounces a day. In other words, it's okay to have a small amount of fruit juice, equivalent about the 1 serving of fruit per day for the child. We don't get our 5 a day, we all know that. That's a discussion all on our own about children not getting their adequate supply of fruit. I can tell you when this came out, the controversy, the reason I got interviewed all the time, was not about the fact that this was too limiting, but the fact that it wasn't limiting enough. The pediatric community wanted us to come out and say, ban all fruit juice for all children. And I said, well, look at the data. I mean, the data doesn't tell you that. The data tells you that fruit juice is pure sugar. It has no health benefits for children compared to milk and water as primary beverages, but it does provide some of the fruit intake. It doesn't have the fiber. It's not. Fruit is always healthier than fruit juice, and that's the take-home message that we want to give kids everywhere. Fruit is healthier than fruit juice. End of discussion of that. But not that you have to take away all food from a kid. And that then leads to, well, let's finish this one. Consider all the value of fruit versus fruit juice we talked about. Reframe discussion of added sugars from how much can be accommodated to what is the role of added sugar. Consider the danger of energy drinks, which I'm not going to talk about today. Let me look at some of the science of things. Okay. Let's then take that discussion and talk a little bit more about sugar in children and sugar and taxes. So I thought, again, since we were going to pick on controversies, let's talk about soda taxes. One of my favorite topics, topic that before I started doing all this stuff with the AP, I was never known was a big controversy. So, let's talk about a sugar tax. Sugar taxes are usually imposed as X amount of cents tax for X amount of volume of sold sugar-containing sodas, usually soda. Okay? They've been tried in a variety of places. Interestingly enough, the benefits and their effects have been mixed at best. Sugar or soda is not the same as tobacco, no matter how much people want to make it be the same thing. The real summary of a lot of different looks at this, including the fact that Cook County put it in place and then reversed it immediately because it was so unpopular. Now, for sure, opposition to soda tax comes from, well, you can imagine what manufacturers are opposed to the soda taxes. But it's not just the makers of Coca-Cola. It's also everybody that sells Coca-Cola, which is just about every grocery fast food place, you name it, in America that's opposed to it. And that's not a small amount of people. Also, a soda tax is a regressive tax by definition, because poor people unquestionably are going to suffer more from it than people who have means. These are really unpopular. That doesn't mean it shouldn't be done. It does mean that soda tax, I'm going to come back to this issue, without having popular support, which means people understand, appreciate, and agree with what you're going to do with the money that's raised by the soda tax, is doomed to failure. But that's not the most interesting policy question about sugar right now. The one that has me fascinated the most and spent the most time thinking about is the SNAP issue. The question is, should we ban soda from the SNAP program? For those who are not familiar with it, basically it's the food stamp program. Okay? So should we say that people who are receiving public assistance to go to the grocery and buy their foods should not be allowed to use that money to buy soda or whatever products you'd like them to? This is a very complicated question. It involves equity issues, very much so. It involves public shaming, which is a big issue, and this sort of thing, practicality, and a lack of even the slightest amount of private data showing any efficacy of it in terms of dealing with obesity. So it's a very interesting debate that's going on. It's not resolved now. I can tell you these are currently being hotly debated. As you can imagine, the current U.S. Congress has one type of perspective on it, because that's where they kind of come from, meaning that you're not likely to see national taxes put into place, because that's not what the current government is at. But from our perspective, we think that there needs to be pilot that. We need to think about these things, or we just say things like, oh, we're going to get rid of obesity by putting a tax on soda. That might be the right thing to do. It might be the right thing to do. It might be the right thing to ban SNAP recipients from using their money for soda. But I'm not sure of that. And I'm not sure that that's an equitable solution to childhood obesity either. What about restricting kids' meals beverages? Same kind of idea, okay? Baltimore City Health Beverages now, all those places have to offer buttermilk and 100% juice. I'm not sure where they got the idea that 100% juice was the same healthy alternative, but whatever. They can talk to me. And their meals. Now, this is the case that I put this up here not because the city of Baltimore did this, but because in fact the people who sell these meals have figured this out as well. How many of you have bought, anybody bought a Happy Meal lately for your kid or for yourself, whatever? Okay, if you bought a Happy Meal, you know that you can now get apple slices with it. You can actually default away from soda towards milk or juices and stuff like that. And that was done voluntarily. That was not forced upon people who sell all those. And we always tend to focus like one company, like the evil devil is Coca-Cola, the evil devil is McDonald's. In fact, there's no difference in the Coke and Pepsi, McDonald's, Burger King, whatever. The companies have done this because they recognize it's in their best interest to serve salads to make their meals healthier. So sometimes pressure from the public and from parents and from people making the right choices is way more valuable than passing a law, in my perspective. All right. And this is what happens when you pass laws that people don't like. Not only do they reverse them, but they make a law saying you can't pass a law to do it, which happened in California recently, which basically said that they banned taxing sodas. I mean, this is what happens when what's well-meaning public policy gets turned into legal action that doesn't have popular support and also hasn't been tested for efficacy. So, to summarize this topic, because I think it's a really interesting and important discussion about what we do for toddlers. There's a real controversy about the equity effects of not allowing it. That is, we're calling them out at the grocery line, etc. No evidence is effective policy, and needs some small trials before any type of national implementation. The Brookings Institute suggested bonuses for healthy purchase is more likely to be effective. Instead of giving people a penalty or not letting them use their benefits to buy soda, why not give them a bonus for buying fresh fruits and vegetables? That's actually much more likely to be an effective policy. All right, the third topic is, which affects kids of all ages, the dietary guidelines for America and the DGAC. So since 1980 and mandated from law since 1990, there are dietary guidelines for Americans. These affect almost every government food, they affect every government food program there is, everything from school feeding programs, preschool feeding programs, to programs for incarcerated people, programs for the elderly, you name it. The nutrition in these programs has to be consistent with what we think we should feed Americans, the dietary guidelines for Americans. There's a committee, the advisory committee, it's formed every 5 years. Holds public meetings, etc., develops an advisory report, the public can respond to it, and then USDA and HHS put together the final dietary guidelines for America. That occurs every 5 years. I served on the committee in 2015. This is a committee that is largely focused on preventing heart disease in middle-aged white males. Okay, that's what the dietary guidelines for America are mostly about. Very little focus on children. By law, they only cover ages 2 and above. So infants were never covered. That changes in 2020, as I'll talk about, where for the first time ever, there will be dietary guidelines for kids up to age 24 months. All right, so I'm going to talk about just one topic of the controversy from 2015, and then finish the last minute to talk about what's going on in 2020. So the most hot topic in 2015 was sustainability. I'm not going to go through, I think you all know the concepts behind a sustainable diet. As a pediatrician, I frame it as in, would we like to make sure that our food supply is consistent with having our children having a world in which this food to eat? Okay? It's that simple. That's sustainability. Many countries throughout the world have adopted sustainability into their food guidelines. Now, when this all went down in 2014, 2015, what was said was that the Dietary Guidelines Committee was trying to ban people from eating meat. In other words, it was said that we're a bunch of vegetarians, so I potentially post on Twitter a picture of myself having a barbecue sandwich, you know, to prove that I'm not a vegetarian. But what we really were trying to say is that a healthy diet and a sustainable diet can coexist because by nature they're the same kind of diet. And that people should look at whether or not how we raise farm fish to make sure it's sustainable and decreasing the amount of meat that we eat consistent with diet with sustainability guidelines. Not that everyone becomes vegetarian. Okay, nothing this sort was ever said. The government and industry went nuclear, to say the least. So what the dietary guidelines report simply said was that a healthy dietary pattern is higher in vegetables, fruits, etc., and lower in red and processed meats. Okay, that was horribly, to me, a very controversial statement, and pretty much true. But the government didn't like it, the industry really didn't like it. The food industry lobbyists, particularly the meat industry, as you can guess, reacted. And they did what the industry does these days, and the reason I put this up was to tell you the latest words. They went to the halls of Congress, and they tried to get the whole dietary guidelines law changed, banned dietary guidelines. Their conclusion was that the Dietary Guidelines Advisory Committee was going to speak out against their food product. The best thing to do would be to end all dietary guidelines. So the idea worked for them. Certainly had a lot of support on Congress. Fortunately, Congress didn't do that. But what Congress did was pass all sorts of, what did they do? They did this in the appropriations bill, right? The law can say we have to have dietary guidelines, but if the Congress doesn't fund the dietary guidelines committee work, it doesn't happen. Okay, so that's how they went about doing it in Congress. To make a long story short, all sorts of things were done or proposed. They proposed that all evidence that was used in dietary guidelines has to have a high grade. Well, since as you all know, nutrition studies are never double-blind randomized controlled trials, almost never. Okay, that's not the way we do it. That's why we do drug trials, not nutrition trials. They basically said that no epidemiology could be used. Student assistance goal focus on epidemiology, so you know that that's problematic, et cetera, et cetera. In the end, what happened was that the government removed all the sustainability stuff from the dietary guidelines. The committee reports out there, and we published it in peer-reviewed journals and all that sort of stuff. And they furthermore said that there would never be sustainability discussed in dietary guidelines in the future either. That America was a place where you could eat whatever you wanted. The dietary guidelines could say what was good nutrition, but we couldn't say anything about the health of the planet. End of discussion. And that's the way it is. Okay? In terms of, we will remain within the scope of the mandate. Because it's in my scope, we do not believe that the DGA is an appropriate vehicle for this important policy discussion. End of discussion. We, the United States, is and will remain a country in which the food guidelines for our children are not taken to effect the sustainability for the sake of the environmental concerns. That's just the way it is. All right. 2020, we're going to cover toddler nutrition for the first time ever. It's going to be exciting and baby nutrition. You can't read this, but the government is making it clear what we're allowed to talk about. They're allowed to do that. They can limit the scope of it. And they've given you can look these up, but basically they're very specific things. Recommended duration of exclusive human milk formula feeding. How much should be given? Dietary supplements, etc. So there's going to be a very tight list of things that we can talk about for birth to 24 months. That doesn't trouble me all that much, actually. Because for the last 3 years, there's been a USDA evidence-based panel working very hard at looking at answering these questions based on the literature. And the results of that are going to be published in HACM within the next couple of months. That is, I'll answer questions like, does prolonged breastfeeding decrease the risk of childhood leukemia? Does it decrease the risk of asthma later on in childhood? So the scientific evidence has been put together by a committee that included me and very others, who've been part of that looking at the literature for the last 3 years, and that's about to be published. So that will be the basis for the DGAC recommendations for birth at 24 months. So this is a huge change, and we'll see how it goes. They also propose very specific questions for adolescents, such as the health benefit of added sugars or risks of added sugars, etc., etc. Okay. So the current status of DGAC 2020, request for nominations for release was due on Saturday. The request specified the ideal members are those who have a moderate point of view. And expect committee to begin public hearings at the end of this year, beginning of next year, report in 2020, and expect the committee to be named next month. All right. That's everything in the talk except for this final slide. And this final slide is pointing out to you that there are challenges and threats to the nutrition of children that never come to an end. So this is a topic which, for those of you who like to Google it or whatever, Twitter it, whatever. And by the way, for those of you who are live tweeting this thing, please look me as @StableIsotope. I'm on Twitter. As is the School of Public Health. It's an issue called public charge. So if you look it up, look at it under the phrase public charge. Public charge is the idea, it's in the law, but in fact has never been enforced previously. It says that determining which legally present residents of the United States are able to get green cards and become permanent citizens of the United States. The government is allowed to take into account their financial viability and whether or not they use public services or have ever used public services. So if this law were to be enforced or used, or if these rules, and it's a very complicated set of rules with lots of exceptions, the thing oversimplified in the media. In theory, a family that was on the WIC could be denied permanent residency charges, permanent residency status. Now, the real power in this is not that they would do that. It's actually fairly unlikely that they would do it. The power is that they're telling people that they'll do it. So imagine what happens if you go around with a bunch of legal residents. There's nothing to do with the immigration debate in terms of non-documented immigrants. Okay? This has everything to do with legal immigrants in the United States who are low income, who use 51% of the babies in America receive WIC benefits, right? That's happening. Okay, this has to do with that 51% who may not be permanent residents yet in the United States, but here legally otherwise. So what's happened is, of course, they stop taking these benefits. When the pediatricians are reporting everywhere, the families are coming to them and telling them that they refuse to show up at the WIC office for fear that they're going to be denied permanent residency in the United States and be thrown out of the country, even though they're here legally in the first place. When asked about it, the Secretary of Agriculture said, "I'll look into it." Okay? So there's this topic, this issue's been around. I've been aware of this issue for over a year now. AAP's been quite aware of this issue. The government's been threatening this for a while. But it's hit the public media big time in the last week or two. So again, if you Google or otherwise look up public charge, you'll see the debate. A lot of really good articles that explain it. It's not as simple. The actual laws and the actual proposals are not simple, but it's a real phenomenon. So, if I would conclude for you, what I'd say is that we're at a time when public policy discussions about infant and early childhood nutrition are everywhere. And there's a lot of different players. Remember that first slide I showed you about who are the players. You have to realize who each of those players are and what their advocacy is. Sometimes I get surprised by who advocates for something that doesn't advocate for something else. And I won't name companies. Sometimes companies behave very responsibly when I think they might not, because they see a bigger picture. Other times, it's very parochial kind of behavior. Our job is to say above everything else what's right for children, what are the rights of our children, and how they get the best nutrition they can, and then look at these while not becoming so fixed on dogma, every baby must be breastfed, or else there's something wrong with that mother, that we cause harm down the road. And that's the challenge of early childhood nutrition now, is to find that balance of rights, that balance of policy, and making sure we understand who all the players are. So with that, I thank you.
Thank you, Dr. Abrams.
for a very, very thought-provoking presentation. It's obvious that there's plenty of work to be done in this area of food policy. And again, really appreciate all your thoughts. My name is Sandra Vandenberg, and I'm a professor of behavioral sciences and at the UT School of Public Health in Austin, and also serve as the Associate Director for the Bell Center. And I'm very honored to be here at this time and invite both speakers to come up to the front so we can have some questions from the audience. And for those of you in Austin, thank y'all for being there. If you have any questions, just let us know.
Y'all know where to find us.
There's some microphones in the back. If you have a question and you'd like to go ahead and ask, please go ahead.
I have a question. So for the second question, so you talk about the juice for toddler, and also the sugar tax. Sugar means soda, right?
Most of the time, the sugar tax has been soda, not, for example, candy. And
So
those companies, yeah, go ahead.
Is soda harmful to toddler?
Is
Or
soda
to
harmful
children
for
or
toddlers?
to
Well,
adults?
is soda harmful for toddlers, is your question?
Yes.
Small amounts of soda. I'm never a believer as a pediatrician and somebody that does a lot of work in pediatric nutrition that we want to identify and say every child that takes this food is causing harm by taking this food. All that does is promote resistance among individuals and societies. Juice itself has no need in the diet. A toddler doesn't need juice. If a toddler has no juice whatsoever, they aren't causing themselves the slightest negative effect. That's not the same as saying it should be banned because it's so directly harmful. It's high sugar. It's everybody's on sugar. It is soda. It has no particular health benefits, and it doesn't have fiber in it. A lot of other things they need. There are some exceptions, some nutrient exceptions, as the juice industry loves to point out to me, and it's almost daily emails they send me. For example, orange juice and vitamin C is an obvious example. Juices are fortified, orange juice in the United States, so some others are fortified with calcium and vitamin D. So it's not a simple relationship. So is juice harmful for toddlers? I would say the small amount of juice can be consistent with a healthy diet. It's not necessary in a healthy diet. And whether or not it should be included in the WIC package is a public policy discussion. It's not really very clear.
Thank you. I'm asking this because I have a toddler at home, and when he goes to the daycare, I really hate they always give crackers, cookies. I think they are the same as juice as soda, just the sugar in there. They change the toddler's appetite, not the energy in there. It's actually make them crave for sweet things instead of natural food.
So the other problem with juices and daycare and stuff like that is there's a tendency for us to put them in bottles with nipples and then leave the bottle in the mouth, which causes all sorts of dental problems. They didn't talk about that today, but there's all sorts of reasons not to be giving kids those fruit juice boxes where they squeeze them into a bottle, not to have the juice sitting in their mouth all day, and for sure not to be putting juice into a bottle instead of giving it to a child.
Thank you.
Hi, thank you to both speakers for being here today. My question is for Dr. Abrams. So you were talking about SNAP regulations and possibly restricting soda, or that's been put out there. From what I know, states have to apply for a waiver to the USDA to do that. So, and you were talking a lot about stakeholders and knowing who to talk to and what their values are. So from your perspective, how would you suggest you make it sound more appealing to the USDA?
So the USDA said clearly that they're not going to do it. Okay. The USDA the directors have literally and specifically said, we're not going to do it for now. But the current U.S. government, may not be the U.S. government forever, and now would be a really good time to try to talk them into collecting some science about it. So the way we'd like to argue the point is to say, okay, let's figure out whether or not there should be these taxes or whether or not SNAP benefits should be restricted, and how to do it perhaps in the most equitable possible way. So we get it, this current government's not going to have a blanket up, and that's fine. I mean, that's just the way our government works, and that's okay. But perhaps the real thing to do is to actually collect some small pilot data and maybe the ET School of Public Health, for example, can get a grant to go out there and look at whether or not limiting SNAP benefits, or particularly the reverse, which is maybe having a penalty for buying soda but a benefit for buying fruits, would actually have some effect. That would be a really interesting thing to do. It's very minimally been looked at.
Yeah, so I have one more question. So with your experience on the Dietary Guidelines Committee, one thing that I've heard about is that some scientists don't feel like 5 years is long enough to really examine new evidence or for new evidence to get out there. So I was just wondering what is your take on that?
So the law says there need to be dietary guidelines, but the law also says that the dietary guidelines should only discuss things that are changed since the previous one. That is, every 5 years we're not supposed to reinvent the wheel. And that's what this government in particular is saying about the next step, is that the amount of effort on adult nutrition will be minimal, because in fact they don't want to change the wheel. They want to look at some very specific issues, the most obvious one being sugar versus fat, without going through that is a big topic. Should we advocate for a low sugar, high fat diet or what matter? That's a false dichotomy, but beyond that, they will take on a few certain issues. But the government limits the number of things talked about each time, because you're correct, it's ridiculous to try to start from scratch. That just leads to public confusion. But this time, the new thing will be birthed in 24 months, and that'll be right from scratch. It's never done before.
So my question is for either speaker, actually. It's a little bit broader. So with respect to both pediatric and maternal health policies, as well as this push towards individualization of medicine and recognizing the limitations we have in research, what considerations have been made with respect to the opioid crisis and how it impacts later health outcomes for children and the health of the mother?
Want to take that one on?
That's provoke.
Yeah. I would say that the American Academy of Pediatrics, and this is not a topic I'm really closely aligned, just be honest with you, is really looking at this issue right now and trying to figure this out. We've all known about opioid addicted babies forever, and that's just part of what we do. I'm a neonatologist clinically. But whether or not, how we look at this from a public policy status, I think is really, and I'm not an expert on that. All I can say is that we need to go about this with some degree of thoughtfulness in terms of how we relate to children. And a lot of the issues that are being discussed now, for example, are things like, is it really necessary to separate the baby from its mother? What are the legal implications of having opioid? Should we be advocating breastfeeding for moms who are using a lot of marijuana? I mean, all sorts of stuff like that. And so it's part of, I think, the broad drug discussion in the United States, and I think there's ways to go with as much clarity.
Yeah, I guess I could only just add that I think there are some initiatives going on at the moment, especially in relation to maternal mortality. Again, I think there are things that have to be done. It's probably going to take a while because essentially they require changes in the system, which are never very simple. We have a number of initiatives. We have one, for example, in the medical school that is being done. The basic introduction of kind of a set of orders for patients after delivery of the baby that minimize the use of opiates. I think we have already some substantial effect in dropping this, just basically making it almost automated. Don't order the opiates. However, this is as Dr. Robert said, and this is a problem out of much larger issue. For example, I practice in Europe, and the United States consumes the vast majority of opioids around the world. But there are also other reasons, and it's not only just because people like to do it or there is abuse, but there's also issues, for example, with insurance. A number of times patients would come in and say, I had a car accident, and I was supposed to have an orthopedic surgery, but I had no insurance to do it. So what happens if somebody prescribes opioids, for example? So it's just an example. I'm not saying that this is the main issue, but it just perhaps a view how complex this is. This is not a simple thing that I can say, we're going just to stop and we're going to change it, because there's so many other factors that play a role in it. And again, development of the guidelines, that's probably very important, although very difficult. As you know, I'm sure we have a lot of guidelines over years. We have guidelines on writing guidelines. And the issue is that I think currently in the United States, about 11% of clinical guidelines are actually based on solid evidence. Estimates of what it comes exactly. And we have made mistakes in the past. In nutrition as well as in otherwise, for example, in obstetric gynecology for a long time we're prescribing estrogens to women based on that was part of the guidelines that we had in the 90s. And we found out actually that the effect has a very negative effect on cancer incidence. I think one has to be very careful making policy changes. And definitely any policy changes should be very, very well grounded in many studies, not one single recent reviewing. And materials for guidelines from the Department of Health. There was 140 pages long documents, and many of those statements that have been made there was based on those tables that there included a single randomized trial, for example, a single observational study. I think I showed you several slides how those work. So I think caution, I think, is important. All these things.
Hi, my question is a little bit more broad as well, so it could be for both of you. Thank you for giving us all that information. For context, I'm a student here, but I'm also IBCLC lactation consultant in one of the WIC programs for our Houston area. My question is pertaining to connections between doctors' offices and families, WIC programs, other breastfeeding support in the community, because I'm wondering, knowing doctors and nurses myself, if education and empowerment of physicians and medical professionals is the better way to go, because parents are looking to their medical providers on breastfeeding issues, or if it might be a community connection issue more than it is getting in there to educate and empower providers.
So for many years, parents went to the pediatrician to say, how should I feed my baby? And pediatricians got their advice from nowhere, except for the formula manufacturers, who came by their office and gave them free samples. That has pretty much ended. No longer do pediatricians have those formula companies guys coming over quite as much. They still do, but not as much. They can't leave them free samples nearly as much as they used to. That's been largely cut back. So now where do parents get their advice from? Google, the internet. So in the United States, every formula manufacturer has a 20-page glossy website that's incredible, talking about why their stuff is amazing. And so we've moved the discussion, and now pediatricians are, when my daughter's a pediatric resident, I train pediatric residents all the time, I can tell you that the average pediatrician knows less than nothing about infant nutrition. Okay, if you're ever working with, that's not the meaning of insulting, the training is focused on disease-based stuff, it's not based on healthy infant nutrition. It just is. The same thing's true for obstetrical residents. That's just that.
No, that's not true. It is.
So we've moved, we have doctors who don't know much about nutrition because it's not where they're trained, not to just not to don't care, but they're not trained to do that. Just like you're trying to teach medical students here some nutrition, we need to do that for our residents as well, and pediatrics and obstetrics. Really want to do that. In that case, it's moved now towards the public media, towards glossy ads, towards things, what they hear from their friend on, from Yelp. Oh my gosh, I put my kid on this new infant formula, and all of a sudden his acne went away, or all this sort of stuff. So how we get about doing that needs to take into account that media is completely different. The way parents get information has changed completely in the last 15 to 20 years. So you can educate doctors, you should educate doctors, you can educate nurses, you should educate nurses. None of them are going to, that's not going to do nearly as much as you think it will, as it is educating the public. And I would argue that the same thing is true for school feeding. we can sit there and talk and pass laws till blue in the face saying that you can't have a soda machine in your school, and kids are going to find a way to get a soda at school. You need to educate families and the kids themselves as to why they should pick healthy alternatives. Anything else won't work. So that's a summary of kind of my perspective on those things. Not that I don't think doctors and nurses should learn more. I don't think you'll get very far. And so we long since sailed the ship. The parents getting their information directly from the internet.
Well, I think this is a very good point. You had something, which I didn't, maybe I just touched upon, but I think it's extremely important. So in very short, I completely agree. I think that, concentrating on physicians or social networks, this is not a question of one versus another. I think concentrating on the healthcare providers is not going to help very much. We already actually did that, to a big extent, because you have one of the five quality measures that you have on performance. One of them is breastfeeding. So how well you perform, basically, and how you judge is how many patients actually have breastfeeding. Probably that's why the initiation is so high. But really, as Dr. Abraham said, what really matters is can you continue, not have you initiated it or not. So what I wanted to touch upon was something called health literacy, which is actually was very close to the big proponents of this work is Gans, which I think I quoted him several times, because this kind of paternalistic kind of practice of medicine is gone. Even if we will try it, it's gone, because access to information is so much more today than ever had been before, and you don't have to ask anybody. You can just you can Google. And so I think what is important is to put efforts not just to provide stimulus information on one particular topic versus another, but actually teach people, public, how to interpret data, because we all are going to do it, one way or another. We are all going to do it. I do it. If I look for a dentist, I look for a physician. I go first and said, okay, I have been in Austin for 2 years. If I don't know somebody personally, I'm going to say, okay, what are the reviews and this kind of things. The same thing with literature. We all have to do it. The information there's so much information. They can't wait for until we have some kind of a statement from an organization, for example. Or even if you do, that you're still going to look for what other people are saying. So I think that what would be really important and would be impactful if we could concentrate and to increase the level of health literacy in the population. And that means how to read Google searches, for example, or studies that they are there.
Right, thank you. Just as a quick follow-up, I know there's another question right behind me, but people have a lot of imaginative ideas about what I do on a daily basis in the WIC office as a lactation consultant. All sorts of very interesting ideas. I haven't touched a mom or a baby more than like 5 times in the last 3 months. It's mostly counseling, and the line I use in absolutely every assessment is, Dr. Google doesn't have a medical degree, don't trust him. So he can get scary pretty fast, so thank you.
I want to say one thing, because I meet with the WIC people in Texas all the time, and WIC has moved very significantly in the last 15 years to being a pro-breastfeeding organization. They do amazing things to support breastfeeding in our culture and our society, and that's a huge change from 15 to 20 years ago.
Thank you very much, Dr. Abrams and Dr. Bukowski, for being here. My question is for Dr. Bukowski. You said that there was an issue with defensive medicine and over-testing. I was wondering, has any hospital actually adopted a reduction in testing for particular diseases like asthma, SLE, and what was the outcome?
I'm not aware of any.
No, not at all?
No, not at all. I think I'm sure there is many reasons. They have been synthesized into this essentially 3 main areas. I think the big one is the lack of understanding of interpretation of literature. And we're basically waiting, for specific information to do it or not to do it. Nobody really looks into the more in detail. That the second part is, obviously we are living in a healthcare system that incentivizes testing and intervening. So it's very difficult to, this is a very powerful incentive, but very difficult to go against it. And this is not my opinion, this is essentially what comes out of the studies looking at this. And finally, the medical legal climate as well. This is a big part of it. If you don't do a test, that always something bad happens. That is always a possibility of finding a neglector, and because we don't individualize, and because we don't accept any adverse events, and we always want to have some cause, some responsibility, or somebody being responsible for it, that basically generates even more tests, and more interventions. And probably part of it is also kind of general societal attitude, and I think that probably relates to the issue with kids that we discussed a moment ago. There is something happens, you have to take a pill, or there has to be something to act upon. And there's nothing wrong with doing it, it's just only that you have to find out severity of the situation that it will justify that. So net benefit. I don't think that anything like this has been done so far. At least I don't know where.
All right, I think we're out of time. So at this point, we would like to thank you both again for great presentations. Before we sit down, we have a little something for y'all.
Well, thank you for the invitation. That was a wonderful.
And I just. And so before I give this to y'all, I know you're both relatively new in Austin. You just recently moved there as well. We're not sure if you're Longhorn fans yet, but you will be at some point. So.
UT is my second favorite football team. You can ask me what number one is, but it's not.
I have some boxes for y'all to take.
Okay, thank you.
Thank you.
So,
Thank you.
Thank you again. At this point, this concludes our presentation. We hope you enjoyed it. We hope you learned something, and we hope to see you again next